Good morning. I am Dr. Saurabh Piparsania. Today I will be discussing on thalassemia. I will be covering the topic under the following heads: introduction, pathophysiology of thalassemia, types of beta thalassemia, clinical presentation, laboratory investigation that are to be done in a case of thalassemia, management, management of complications, and iron chelation therapy. Before discussing thalassemia, I would like to discuss about the composition of blood. We know that blood is produced in the bone marrow and it is made of two parts: plasma, which is approximately 45% of blood and is made up of water, salts, and protein. And second is cells, which carries oxygen and is made up of RBCs, WBCs, and platelets. The function of RBCs is to carry oxygen to different tissues of the body. WBC plays an important role in providing immunity, and platelets plays an important role in clotting of the blood. Normally, hemoglobin is present in the RBCs, which carries oxygen to the various tissues of the body. Hemoglobin is made up of two parts, a heme part and a globin part, which is a proteinaceous part. Globin part is made up of two chains, alpha chain and non-alpha chains. The alpha chains combines with the non-alpha chains to form tetramers. Any defect in this globin chain, either in alpha chain or in non-alpha chain, may lead to production of defective hemoglobin and may lead to hemoglobinopathies. Now, a few words about hemoglobin synthesis. Hemoglobin synthesis during intrauterine life occurs in the yolk sac during the first 6 weeks. After that, liver takes over the responsibility of producing blood, and spleen also participates in the production of hemoglobin at around 16 to 18 weeks. So at the time of birth, the principal site for the production of hemoglobin molecule is liver, spleen, and bone marrow. The switch of hematopoiesis from liver, spleen to bone marrow is completed at around 6 to 8 weeks in postnatal age. So during postnatal age, during the initial few weeks, hemoglobin F is the important hemoglobin molecule in the newborn. The normal hemoglobin is made up of hemoglobin A, which is alpha 2 and beta 2, and it is approximately 98% of the total hemoglobin molecule. Fetal hemoglobin is approximately 1%. It is made up of alpha 2 and gamma 2 chains. And HbA2 is less than 3.5% and is made up of alpha 2 and delta 2. This is the composition of the normal hemoglobin molecule, and it is made up of hemoglobin A, mainly hemoglobin A, fetal hemoglobin, and hemoglobin A2. Now coming to the thalassemia. Thalassemia is one of the most common inherited disorder of hemoglobin synthesis, in which the rate of synthesis of globin chain is reduced. Depending on the type of the globin chain affected, it is classified into beta thalassemia and alpha thalassemia. Beta thalassemia is characterized by reduced or absent synthesis of beta chain, while alpha thalassemia is characterized by reduced or absent synthesis of alpha chain. Now, alpha thalassemia, in this the alpha globin chain synthesis is affected due to the defect in the alpha globin gene. When there is affection of one alpha globin gene, the individual will have only mild microcytosis and no other complaints. When two globin genes are affected, patient will again have mild microcytosis. When three alpha globin genes are affected, the patient will have hemoglobin H disease. And when all the four alpha globin genes are affected, the newborn will have hemoglobin BART or hydrops fetalis, and this type of hemoglobin is incompatible with life. Beta thalassemia, it is characterized by reduced or absent synthesis of beta globin gene. So because of the decreased or absent level of the beta globin, there is excess of the alpha chain, which forms tetramers and red cell inclusion bodies, which causes premature hemolysis of the RBCs and various clinical manifestations because of this hemolytic feature. So presentation is: thalassemia should be considered in any child with microcytic hypochromic anemia that does not respond to iron therapy. Children are usually asymptomatic till first 3 to 6 months of age because during this age, HbF is present in a significant amount and the usual manifestation of beta chain depletion or absence are usually not present. In some cases, it go unrecognized because of the delay in cessation of fetal hemoglobin synthesis. Severe pallor and hepatosplenomegaly are almost always present in a child with thalassemia. Clinical feature consists of features of anemia. The child usually will have poor appetite, poor weight gain or growth failure, irritability, easy fatigability or exercise intolerance, cardiac murmur, which is known as hemic murmur because of the severe anemia. Bony abnormalities are common presentation and presents as in the form of frontal bossing, prominence of the facial bone, malocclusion of teeth, and depression of the nasal bridge. On systemic examination, one can see hepatomegaly, that is enlargement of the liver, and splenomegaly. Features of ineffective erythropoiesis may cause fever and failure to thrive in this child. Beta thalassemia can present in a various form and is classified as beta thalassemia trait. In beta thalassemia trait, there is only a slight decrease in the synthesis of the beta globin gene, due to which patient will have mild anemia, abnormal red cell indices, that is MCH, MCSC, MCV. On doing HPLC, that is high performance liquid chromatography or hemoglobin electrophoresis, one will get elevated HbA2 levels and fetal hemoglobin levels. And on peripheral blood examination, one will get microcytic hypochromic picture along with target cells. Second variety of beta thalassemia is beta thalassemia intermediate. Again, the child will present with anemia. This patient may or may not require regular blood transfusion, and usually splenomegaly is present. Third is thalassemia major. It is the most dreaded type of beta thalassemia because of almost absent synthesis of the beta globin gene. So the patient would have severe anemia, which often require regular blood transfusion, bony deformity, enlarged liver and spleen, growth failure, hemolytic facies in the form of frontal bossing, depressed nasal bridge, maxillary prominence, and maloccluded teeth. On peripheral blood examination, one will get microcytosis, hypochromic picture, nucleated RBCs, target cells, and anisocytosis. On doing X-ray of the skull, one may get hair on and appearance. This is a picture showing a child with classical beta thalassemia syndrome, in which you can see a frontal bossing, depression of the nasal bridge, prominence of the maxillary area, maloccluded teeth. This also means chipmunk species. This is the X-ray of the child with beta thalassemia major, X-ray skull, which shows hair on and appearance. Another type of beta thalassemia is beta thalassemia with beta chain structural variants. These patients may have mild to moderate symptoms like thalassemia minor or intermediate, or major symptoms like thalassemia major. So this variety of patient can have features of any type of thalassemia, minor, intermediate, or major. Now, what is the epidemiology? Every year, about 100,000 children are born with thalassemia major worldwide. Approximately 9 to 10,000 children are born in India alone. About 65,000 to 67,000 patients are present in our country, and 30 million children carry the defective gene for thalassemia. The carrier rate varies. The carrier rate is 1 to 3% in southern India and 3 to 15% in northern India. It is common in certain communities like Sindhis, Punjabis from North India, Bhanushalis, Kuchis, and Lohanas from Gujarat, Mahas, Neo-Buddhists, Kolis, and Agris from Maharashtra, Goda and Lingyats from Karnataka. These are the communities in which thalassemia trait is very common. Now coming to the laboratory diagnosis. Diagnosis is made on the basis of the clinical features and laboratory investigation. The following investigations are done. On doing complete blood count, you will get anemia and leukocytosis may or may not be present. The reticulocyte count is usually more than the normal. It is in the range of 5 to 8%. Red cell indices like MCV and MCH, they will be low. On doing peripheral smear examination, one will get microcytosis, hypochromia, polychromatophilia, nucleated red blood cells, and fragmented RBCs. Shift to the left is also encountered reflecting hemolytic process. On doing hemoglobin electrophoresis, hemoglobin A is absent and fetal hemoglobin is elevated, which suggests thalassemia major. While elevation of HbA2 alone is suggestive of a thalassemic trait. Now, the management and complication that we can see in a child with thalassemia. Thalassemia major is a transfusion-dependent condition, and blood transfusion is given at a regular interval. It should be initiated at an early age when the child is asymptomatic. You have to maintain pre-transfusion hemoglobin level of more than 9 to 10 gram per deciliter. And the type of blood which we prefer to transfuse is red cell concentrate or PCV, that should be leukodepleted or washed RBCs, because leukodepletion and washed RBCs minimizes the chances of reactogenicity in the recipient patient. Folic acid is routinely given to a child with thalassemia along with vitamin C, D, and E. The only curative treatment that is available for patients with thalassemia is hematopoietic stem cell transplantation, but the availability of donor is always an issue. Genetic counseling of the parents should be done in all children who have been diagnosed with thalassemia major to determine whether the parents are trait or carrier, or they have the other type of thalassemia. And it also helps in determining the chances of another offspring born with thalassemia major or other type of thalassemia. Iron chelation therapy is done for iron overload state. And please remember, do not give iron preparation. Iron is not given in a child with thalassemia. Transfusion is a life-saving. All children with thalassemia major who are on regular blood transfusion should be immunized with hepatitis B, H influenza type B, and meningococcal vaccine, because these children will have increased risk of infection because of these organisms. Splenectomy is done when transfusion requirement is more than 200 to 250 ml of RBCs per kg per year, or when there are signs of hypersplenism. Splenectomy is usually done after the age of 5 years. And before doing splenectomy, ensure that the child has been vaccinated with HIB, that is H influenza type B, hepatitis B vaccine, pneumococcal vaccine, and meningococcal vaccine. Hydroxyurea is indicated in patients with XLM1 mutation, and it is a modality of treatment that is being employed nowadays for the treatment of child with thalassemia major. In children with thalassemia trait, follow-up is usually not required after initial diagnosis, because this patient usually does not develop severe anemia or other signs of thalassemia. Complications that may occur are iron overload because of the regular blood transfusion. This patient may develop overall iron overload state because of increased GI absorption. This iron is deposited in various organ systems of the body, mainly liver, heart, and endocrine glands, leading to hypothyroidism, hypoparathyroidism, low level of the growth hormones, diabetes, hypogonadism, cirrhosis of liver, cardiomyopathy, and arrhythmias. So, in all children with thalassemia major who are receiving regular blood transfusion, workup for all these conditions should be done. Other complications are psychosocial complications, because as the child is not growing nicely and they often require frequent blood transfusion, they may suffer from some psychosocial complication. Because of extramedullary hematopoiesis, they have hemolytic facies. Bone changes may appear like hair on end appearance and growth failure. These are the other complications. Now, how much iron overload does transfusion cause? Normally, 1 ml of red blood cell contains 1.08 milligram of iron, and 1 unit of blood contains about 200 milligram of iron. So, a patient who receives 30 units per year receives approximately 6 gram of iron in a year, and the body is unable to excrete this much amount of iron. So, this is a slide showing complication of the iron overload. These are liver fibrosis, arrhythmia, hypogonadism, diabetes, hypothyroidism, hypoparathyroidism, and cardiomyopathy. And death is mainly because of the cardiac complications. Now, how to deal with this excess of the iron that has been deposited in the body. Here comes the role of chelation therapy. The word chelation means removal, and iron chelation means removal of the excess of the iron from the body. An iron chelator is a drug that removes the excess of the toxic iron from the body. Now, how does the iron chelator work function? The iron chelator binds to the iron and it forms a complex, and this complex is then excreted from the body in a non-toxic form. Aim of chelation therapy is to remove excess of iron from the body and maintain negative iron balance. That is, rate of removal of iron through chelation therapy should be more than the rate of iron loading through transfusion and GI absorption. Indication of chelation therapy and the drugs that are used for chelation are: indications are when the ferritin level is about 1000 to 15,000 microgram per liter, liver iron concentration is more than 2500 microgram per gram of the dry weight of the liver, and it is usually indicated after 1 year of transfusion therapy. Drugs available for chelation are D-ferroxamine, which is given subcutaneously for 5 days in a week. Deferasirox, it is given orally, and deferiprone, it is again given orally. Thank you.